طبعا very difficult even when I was in my residency. It had a lot of controversies, a lot of information, وخاصة in a region where we didn't used to see a lot of melanoma, but going abroad, it was one of the most common things, the most important things to know about in details. I'd love إنه حتى حنا with our globalization that's happening in Saudi, I do see a lot of non-Saudis, especially people with Caucasian background. So we will see these patients, and if we don't treat them, then that's a problem if we don't have standard. So in this talk, I'll go as literally your reference textbook, which is Clinical Dermatology by Jean Bologna. And we'll go through the things, and I'm very happy to share the slides. I have no problem at all. But what I need is people to understand the concepts here, okay? There's a lot of talk. I'm not going to read everything, but to know that this is a summary of the book, okay? So first, we'll talk about molecular pathogenesis, epidemiology, just like any chapter, but we'll go through that, inshallah, slowly. So bismillah. First, we'll talk about melanoma. Melanoma is, as the name reflects, it's a tumor from melanocytes. But one thing about it, it's melanoma, not melanocytocarcinoma or melanosarcoma. So it might elude you that it has a benign nature, but no, it includes only malignant melanocytic tumors. Originates from cutaneous melanocytes with no neural crest origin, and that's why we can see it in other regions like mucosal surface, uveal tract, in different locations on the eye, as well as leptomeninges. These طبعا melanocytes are different, but they have oncogenic potential. طبعا there's key oncogenic pathways. Excuse me, just one second. هلا أنا محاضرة. ايه انا بالمكتب. That's not once. Sorry about that. So oncogenic pathways, here we're going to start talking about important stuff, okay? So what happens, there's activating mutation that happen in these cells. So in two central pathways you really need to know about: the mitogen activated protein kinase pathway and PI3K pathway. And whoever trained or worked with me, you'll notice that we always say PIK3CA, PIK3CA, in a lot of vascular noises. Just tell you how they share a lot of commonality. And these pathways are responsible for proliferation, resistance to apoptosis, and enhanced survival and tumor progression. So this is what we see and what it is. So you have a receptor kinase, tyrosine kinase. Once activated, what we say is Raf Ras Mik Irk. Raf Ras Mik Irk. And as you can see, they all they're downstream. And from ERK, it goes down to the nucleus, cyclin D, cyclin D1, CDK4 and 6, all the way to the retinoblastoma, E2F, all the way. This activates DNA to produce and proliferate. And you can see the target of multiple therapies, and that we will mention during the, but this is a very important site. The other pathway, as you can see, is the PIK3CA pathway. Same thing, kinase, but you have the phosphoinositide 3 kinase, which gets phosphorylated. And once that activation occurs, ACT is one of the proteins involved, and whoever knows vascular anomalies, it's related to Proteus syndrome. Pitin is one other which inhibits, and this pitin is associated with Cowden, different other like Banyan-Ruvalcaba syndrome, etc., and Solomon syndrome. And then inside mTOR, again, we hear about mTOR with sirolimus and all these, plus things like tuberous sclerosis and other conditions. So just to tell you that a lot of similarity with other conditions. So melanoma, what happens, it's a very immunogenic tumor. But what happens before this tumor develops is you get a mutation, then a second mutation occurs, and then the tumor. So you can have multiple mutations in different locations. The ones we mentioned are the most common, but you have others as mentioned here. We talked a little bit about the cyclin D1, CDKN2A, given that it has a syndrome associated with that, P14ARF, or P53. This is an important table, okay? And I really want the residents to listen clearly about this. This, if you know this and understand it well, like RAF also gets replicated in Langerhans cell histiocytosis. You see the type of mutation and type of treatment and which type of melanoma occurs. For instance, the RAF mutation, BRAF, is usually in high CSD, means cumulative sun damage melanomas, okay? Compared to, for instance, like RAS, also high, but you see it in low as well, acral. Each one could be different. Like each type of melanoma could have different types of mutation. But for instance, here, KIT, we see it with acral. GNAQ, GNA11, we see it with UVL, melanoma. And others. For instance, we've been quizzed once about Spitz, melanoma, and it was the RAS, HRAS, okay? And TRK1 as well. And this is the CDKN2A. There's the CME and the JAD talking about familial melanoma syndromes. And these exist. I've seen cases with these, and you see the mutation. It helps with treatment decision. Other, as you can see, you can go through this table by yourself, but BAP1 also causes what we call BAPoma or BAP1 tumor syndrome. We'll allude to that later in the presentation, and others, as you can see. And the problem with these mutations, not only that they cause melanoma, they also cause tumors in other organs like pancreas, mesothelioma, etc. Like, what influences the mutation patterns? Mutation depending on, so whether or not the melanocytes are epithelial versus non-epithelial, the level of damage, the sun damage, that's what I was saying, high CSD versus non-CSD or low CSD, and the mole phenotype and nevus burden, as in the syndromes we talked about, like BAPoma, etc. And that was what I was saying. BRAF, more mutations with intermittent sun exposure, and RAS more frequently in chronic damage skin, sun damage skin. The immunogenicity of melanoma. So it's a highly immunogenic tumor. Expresses proteins that expose the immune system, and then the innate and adaptive immune systems tries to attack it. And this is what we see on clinically, is we see what we call regression, and sometimes even whitening, and sometimes you get vitiligo-like. That's why when you have a hyalinevus and you see vitiligo developing around it, you have to search to make sure there's not a melanoma. And if that develops, that's a favorable sign. And you can see it as well in pathology. So what are these antigens? We have a lot. And this is an example of them. And if you read these names, whoever did immunochemistry in pathology, this is what we target in pathology. And these are the proteins who expose this cell, and then the body starts attacking. And sometimes it doesn't differentiate between melanoma and regular melanocytes. So these antigen activate cytotoxic T cells, and this is very important. Later on, we'll talk about that in detail. This part, guys, you have to know, because this is what, this is the basis of the new targeted therapies. So the T cell activation are present. Melanoma antigen starts getting identified as cytotoxic T cells through the antigen presented. But what happens here is you have the B7 molecule attaches on antigen-presenting cells, CD28 on CD8 T cells. Why does this happen? This co-stimulation enhances T cell proliferation, survival, and cytotoxic activity. The activated CD8 T cells target melanoma cells that have been exposed, okay? Then we have these two proteins, CTLA4 and PD1. CTLA4 is an inhibitory protein. So what does it do? It inhibits the stimulatory action for these T cells, so it causes suppression. So It's an inhibitor of the T cells. And why is this? I mean, the body has its own way to regulate, so you don't self-attack. But the tumors are very smart, and they start escaping. So if the CTLA4 is blocked, they can escape through the programmed death protein 1. And this is another inhibitory protein. So PD1 binds with PDL1 or L2. These PDL1 and L2 are on the tumor cells. PD1 is on the effector cell. And this will lead to apoptosis. If this attachment happens, it will kill these cells and protects the Tregs because it wants to balance the immunity. Very nice. So now we'll come to that later on in the talk. I just wanted the concept to be very clear. So when we talk about therapies, it makes sense why we use it. What are the risk factors? Male, more than 60, red hair, blue eyes, Fitzpatrick type 1 and 2, easy burn, not tanning. And what I find important is the fact that you get burns, especially when you're young. Just see this one, intense intermittent sun exposure, as well as blister burns when you're young. All these make sense, okay? But let's talk about the number of nevi as well as atypical melanocytic nevi. If you have more than 100 melanocytic nevi, your relative risk increases. The quiet ones. If you have 5 atypical melanocytic nevi, your as well risks increase 4 to 6 fold. Solar lentigens, actin keratosis, SCC, BCC, all increase the risk. So it can occur mainly on type 1, type 2 skin, but it can involve any race. And just thinking about it, I've seen it in almost most of the races if we break them up into big groups. There is steadily rise over several decades and almost doubling in the white population. But whether or not this is affecting survival, it's a big question. I mean, we don't know if the mortality is increasing. In some studies, it actually says there's no change in mortality. The rise could be because of increased detection. And other possibility is that people's attitude have changed. And this is why we tell people be careful of tanning. Because in our grandparents and moms and great-grandparents, they used to not tan as, let's say, luxuriously as people are doing now. So we don't know the impact of what's going to happen later on. Age-related risks, their incidence in younger people is increasing, although it's modest, okay? The largest is by far in the older age groups. But as I mentioned, the mortality did not have that much change. Familial melanoma, it accounts for around 5 to 10% of melanoma. It has high penetrance from a genetic point of mutation. Major one, as it's telling you, is CDKN2A. The reason is not only that it causes only melanoma, it also could cause tumors in other organs or locations. And you can see other key mutations have been involved. And these are other mutations. Each one presents with different type of, let's say, tumors and other features compared to each other. So when do we need to check someone for genetic testing? And you can say, I do like this table. I say if you have 2 or more relatives, particularly first degree, who have cutaneous melanoma and or pancreatic cancer. Pancreatic cancer, they said 3 or more. Because it doesn't make sense all 3 or 4 members have pancreatic cancer in the same family. That makes you raise suspicion of CDKN2A. Personal history of more than 3 invasive cutaneous melanoma, 1 of them before 45. 1 embate or papilloma, we'll talk about that in a little bit. And family history of mesothelioma, meningioma, and or uveal melanoma. 2 or just 2 bapomas. Bapomas, we'll talk about that. So BAP1 tumor syndrome, this one was originally linked to aggressive uveal melanoma. There have been different malignancies of them: cutaneous melanoma, uveal, mesothelioma, renal cell carcinoma. Additional but less is BCC, meningioma, cholangiocarcinoma. It's just like Gorlin syndrome and other syndromes. It just predisposes you to different tumors because it's a tumor suppressor function loss. And actually, I've seen this, and I've seen a case of this. This is how they look. They look like almost like dermatofibroma. It's usually skin color to pink. And these are what we call bapomas. In oncopathology, they have characteristic epithelioid melanocytes, and they have loss of BAP1 staining. And we mentioned this, the more melanocytic nevi you have, the more likelihood of developing melanoma, especially when they're large. And this is strongly associated with subtypes, superficial spreading, and nodular. And it's one of the most reliable and reproducible risk indicators. What about atypical nevi? Same thing. The sporadic ones without the familial syndrome ones, the number, as we said, 5 or more, increase your risk, and it goes up and up with a higher number. As you can see in some studies, 32-fold with 10 or more atypical nevi. So age group, as we said, could be in the young and the old. This just explains that biologically and genetically they could be different. One is early onset with intense sun exposure. The second is more cumulative sun damage with time. So the early one is low cumulative sun damage. The late one is more high cumulative sun damage. Okay, this one's younger age group. This is older. This is intermittent UV exposure. This is more high cumulative. The types of mutation BRAF and RAS here. Lentigo maligna is more associated with the late onset, and you can see the location and the subtypes in each. All right. So UV, again, why? And there's a problem. Okay, keratinocytes get UV damage a lot, but they have the ability to repair faster than melanocytes. Melanocytes have less ability to apoptose compared to keratinocytes, and that makes the melanocyte that's damaged progress, and with the mutation, it could further proliferate. Both UVA and UVB contribute. UVB is a stronger carcinogenic driver because it damages DNA. That's its target. So artificial UV, and this is what we talk about, is two things. We have artificial from medical artificial, or artificial which is commercial, like the ones we use in indoor tanning. And this, for sure, above 10 sessions of indoor tanning, it causes risk increase of melanoma. And WHO and other agencies consider it as a type group 1. I don't know what that means exactly, but I assume it's labeled as a high level of risk and something you can prevent. So this is a type of lesion you see. I mean, in a perfect world, you see it that ugly, but this is kind of a prototype. So what subtypes? We're going to the clinical findings now. So chronic cutaneous melanoma, classification keeps changing, but the major subtypes are superficial spreading, nodular, lentigo maligna melanoma, acral lentiginous melanoma. Okay, this is based on the clinical appearance, growth behavior, and the type and or the genetic mutation. WHO in 2023 classified melanoma into 9 major subtypes. There is low cumulative sun damage melanoma, lentigo melanoma, desmoplastic, Spitz, acral, mucosal, melanoma rising in giant congenital nevus, melanoma rising in a blue nevus, and ocular. So it seems how there is shifting here and there, But at the end, knowing, because sometimes they're clinically separated, some of them you only can tell by pathology. Back to this picture. This is the most common, is what we call superficial spreading melanoma. It has, and get used to this word, low cumulative sun damage, low CSD. This, I think, is going to be entertained further and further in classification to separate between the burden of these tumors. So it's the one that could occur most commonly in a pre-existing nevus, but also can occur in de novo. It's the most common in subtype of cutaneous and light-skinned individual, age, just like most of melanomas, but this slightly on a younger scale, 40 to 60, counts for 70% of melanoma across all anatomical sites. Right. It varies by gender as well, men in the trunk and back, women legs and trunk. Again, we talked about intermittent rather than chronic, persistent sun exposure. Can occur in any site and often associated with people with numerous type of melanocytic. Growth pattern, again, use these words for melanoma is very important. Radial growth, which is a horizontal growth, and vertical growth. Of course, the radial is better. Vertical is, because we'll talk about microstaging in a little bit and it'll make sense. So sometimes the melanomas as you can see in this melanoma, probably it was radially growing here and then vertically grow here. When you vertically grow, you start getting nodular and papillary lesions. All right, speaking of nodular, you come to the second subtype, which is nodular melanoma, second most common, lightly pigmented individuals, typically diagnosed in 6 decades of life, more frequently in men than in women, represent 15 to 25 of all cutaneous melanoma, can arise on body site, most often trunk, head, and neck. Just to tell you guys, I know in Alhamdulillah, Saudiya, we don't get this much. But in North America, every clinic, sometimes one patient, you have 2 or 3 melanomas detected in the same session with a basal cell and squamous cell. So alhamdulillah, we're lucky from that perspective, is that it's not as a big of a burden, but with lifestyle modification as well as excessive immune suppression and prolongation of survival with medication, we might see a shift in these numbers. Nodular melanoma usually arises de novo compared to superficial spreading. This is the bad part of it. It goes to a vertical phase directly compared to a radial. Okay? It's one of the most aggressive types and has metastatic potential. All right? That's for nodular melanoma. All right. This typical old person, patchy, different pigmentation. This is lentigo maligna melanoma. Counts for 10 to 15%. Typically diagnosed later. This is the one that occurs more in older patients, and it tends to be with chronic and cumulative sun damage. Most common location, as you can see, face, nose, and cheeks, as well as scalp and people with androgenetic alopecia. Slow growing, progressing over years. Very, very slow. So, and funny enough, I had here in Riyadh, I had someone visit an aesthetic practice. This was a few years ago, and she complained of melasma or calaf that does not go away. And I look at it on dermoscopy, I'm like, no. And she refused the biopsy and she disappeared. But I told her this is most likely something that needs to be excised. It could be a lentigo maligna versus a lentigo maligna melanoma. When we say lentigo maligna, we mean melanoma in situ, okay? And 5% of them could shift to an invasive melanoma. And usually they have a very slow radial expansion, and it's important to detect it earlier to make easier space for treatment. This is a heel of a person, and as you can see, a smudged brown stain that could be easily confused with ecchymosis, fungal, or whatever people like to call it. When you see a persistent brown-black lesion, don't ignore it. A biopsy is highly recommended. And in Saudi here, out of all the melanomas, this is the one I've seen in people, even if they didn't have any previous history of, let's say, transplant or immune suppression, and in different like regions, from different regions, and not specifically in a certain tribe or city or whatever. I've seen it in couple, and it took a while to diagnose because it was not thought about directly. Endoscopy, this helps a lot with the ridges and furrows and how it disrespects that. So this is an uncommon subtype, represents 2 to 5% of all melanomas. You have to understand these textbooks mainly rely on data from the West or the East, not necessarily for the Middle Eastern population. It's usually diagnosed in the 7th decade of life, occurs in acral sites like palm soles, nail apparatus, and this is what we have like subungual melanoma. The question is it associated with a lot of UV exposure? It doesn't make sense because of the locations, but it's not as the ones previously mentioned. And I was saying it's always confused by a traumatic injury like a ecchymosis or hematoma or something under the skin. It's overrepresented in darker skin types like African, Black, Asian, Hispanic. Least common in the white population, but overall it's not common. Okay. This, unfortunately, I've seen this a couple of times, and what you see here is a dark band that's covering most of the nail, a little bit of hue on the nail fold here, as well as you can see maybe notching here of the nail. But one thing about it, it's very wide. This is more than 3 millimeter. It has different shades of black brown, and it doesn't have a regular appearance. So this alludes to something growing here and should not be ignored. And this is what we call subungual melanoma. And this is a type of acronotigus melanoma. So as I was saying, the band is more than 3 millimeter, dark, so usually solitary. So we have a lot of people who have genetic melanonychia. Usually it's a small thin band, different nails. That's totally fine. The more it's on a single nail and you have these features, this makes the likelihood very high. And when it extends beyond the nail into the surrounding skin, we call it Hutchinson sign. So what is genetically for acronotigus melanoma? It does not typically present the UV signature mutations. It has frequently activated mutations. The KIT gene addition are the ones mentioned. Talking about melanoma, why is this not pigmented? So this is why we call this amelanotic melanoma. One thing about this, I see this, you have a pigmented BCC that looks like a melanoma, and you have an amelanotic melanoma that looks like a BCC. So it lacks the typical pigmentation present as pink red flesh color. It's very difficult. Just that lesion that does not heal and it oozes and bleeds, that's usually how people complain about it. And imagine this being subungual, that even makes it worse and worse. Next subtype is spitzoid melanoma. So melanoma with features of spit. This is different than Spitz melanoma, okay? Because histologically it has the same Spitz nevus like pathology with epithelioid spindle-shaped melanocytes. It often has low cumulative sun damage type of melanoma. Frequent demonstration of mutation involving BRAF and NRAS. This is important in its causable area. So the one from Spitz differs it has the mutation is different, as you can see, and these are the ones associated with melanoma developing in a spit. So it's important to know to differentiate because the behavior is slightly different. But all these are not common types. So this, you can see the color. The color is blue, and these look like satellites. And you have a nodular component. This is what we call melanoma rising in a blue nevus. Most commonly a head of scalp, blue-black nodule, usually big in size, has high rate of recurrence of metastasis, and the genetic mutation GNAQ, and less likely GNA11. So as you can see, this is the eye, and this is conjunctiva, and you can see something growing out like this. And taking this is ocular melanoma. It's a rare subtype divided in conjunctival and uveal. The uveal one commonly harbors GNAQ and GNA11. It has similar pathways to blue nevus. Prognosis, of course, depends on extension involvement, and this usually goes to ophthalmology. Mucosal is very challenging because it can occur in all mucosa, and sometimes, unfortunately, become amelanotic as well. So that makes it very difficult to diagnose. And the frequently harbored mutation is KIT, again mentioned that, and it has aggressive and poor prognosis. Desmoplastic melanoma is one thing, is more pathologically, but it has a lot of spindling and like the stroma around it, fibrous and desmoplastic. Say desmoplastic, we mean by this fibrous and spindly type look. And clinically, it could have an appearance of an amelanotic-like, and usually arise on chronic sundown skin, could be de novo or with association with other types of melanoma. So you can see this desmoplastic change in the melanoma, okay? But it's always here, desmoplastic, usually it's not a good prognosis. So in peds and adolescent, it's rare. But when you have it, raise the concern of a genetic. I would check them genetically directly. Unless they have a very frank, clear diagnosis like xeroderma pigmentosa, you've already probably done the genetic. The giant congenital melanocytic nevi is obvious, so that's another one that unfortunately you can see melanoma. And there's not much difference. But one thing is, just wanted to mention it here, the ABCD that we always talk about is different in children. We used to say A for amelanotic because usually they get, the ones that get the amelanotic are the pediatric. They bleed, color uniformity, and de novo appearance of any diameter. So since we mentioned the ABCDE, probably most of you know it. It's actually important education tool. I think they did a very good job because it helped public awareness and it's easy to memorize. Other signs like ugly duckling sign, I honestly used to rely on this because when you see a Caucasian person with 300 types of lesions on their back and skin, with this chronic skin damage, when you see something outstanding on your eye, this is what they mean by ugly duckling. It's like appearing in between the regular. So we had the word, we said, this is the signature nevus for this person. So any change of this nevus pattern is considered abnormal because everyone has their own signature. And other things like EFG, this might be more, let's say, academic and theoretical. All right, so dermoscopy. I know you have a talk on dermoscopy, so I didn't want to go into that, and I'm not that expert, but you don't need to be really an expert to detect abnormality. And the importance of this is just to increase your accuracy of diagnosing, as well as decrease the unnecessary need of biopsies. And what you look for, there's a pattern, the pigment network, regression, color, globules, vascularity, and different aspects. This is a good table for review. I would highly recommend knowing it very well. And this just differentiates between melanoma, some features of it, and other benign and malignant melanocytic and non-melanocytic lesions. Let's go to microstaging. So, an outcome assessment. So, microstaging is important. So, when you wanna uh, diagnose a melanoma, you have to make sure you take a good sample that will reveal or reflect the Basal depth. So, Basal depth is probably by far the most important factor when it comes to risk of metastasis, survival. So how do you measure it? And I've seen it actually live. If you sit with a pathologist, they'll explain to you. You go from the top of layer of the granular layer and you measure all the way down. If it's ulcerated, then you go from the base of the ulcer down. This, good luck. I think this is something you need to memorize, especially before the exam. It's not easy, and you can see they keep changing, especially with T1, T1A, T1B, and they keep splitting because every time they notice there's difference in outcome and recommendation of therapy. So I highly recommend knowing your TNM staging, and good luck with that. And this is the AGCC8. And if you want to go further, you can go to their website. It has very detailed description of how the stagings occur, but it tells you how difficult it is. Look at the survival. It doesn't necessarily go in parallel with the, I guess, progressively with the numbers. If you can see here, it's 86, then it's 90. Then it goes 93. So it's hard and it's difficult. So I do think you should know it for the exam, but know that overall, it's melanoma is one of the most difficult tumors. And hopefully, if we have time, I'll give you a couple of things I experienced with this tumor with patients in the past that were beyond what we think in staging in all these different risk managing procedures. So when do you consider a sentinel lymph node versus when you have to do it? Okay. So I think that the big debate is here. Should we do it for 1B or not? And beyond that, usually it's highly considered and done, usually for these stages. Okay. Of course, from 3 and above, but from these, as you can see, they still don't have very clear consensus, and different studies try to see whether or not doing it early will change survival versus not. Immunohistochemistry, I think pathologists will talk better than myself about this, but knowing that melanoma, we use certain stains, and this helps differentiate. These are specific, so they can actually detect a melanocyte origin or melanocytic lineage. And after that, you can detect also like K67, SOX10, S100, different stains that are less specific but help. And these could be seen in other types of tumors. Molecular wise, this is what they do in the lab, and we do this sequencing because occasionally it does help. Some tumors automatically go for sequencing, and this helps you in the future, especially with targeted therapies. I was talking about the sample. Make sure when you take a sample, cut it easily. Don't do shaves for melanoma or suspected melanoma, because when you shave it, you're interfering with the Brasilow's depth. And when you interfere with Brasilow's depth, it's very difficult to stage the melanoma. Of course, a punch could be done. The punch biopsy should be around 3 millimeter, and full excision or elliptical excision could also be done, an excisional biopsy, which also is an incisional biopsy. But at the end, your margin that you should take will be detected after you know the depth and the stage. So these are independent prognostic factors for survival. Okay. You see, mitotic rate in the past, they used to put it in the staging. They took some of them out, like ulceration. So these impact, but then not necessarily all of them are put in the staging system. And I do say, whoever is studying and reading the staging system, it's really hard and it's a difficult system. But know that probably it's because of the different behavior of this tumor. So different labs, depending on the situation, the more risk of metastasis, you have to evaluate the patient. So general recommendation 2B and above should be imaged, one of the CT cap, as well as PET CT to detect hot locations. And this is kind of the symptoms and what to do if the symptoms are present. So excision margin, and this is very important, and I think it's an area of debate, but it really depends on the Basal depth to choose how much margin you're going to take with your excision. So when it's an in situ, you're okay with 0.5 up to 1 centimeter, okay? If the depth is less than 1 millimeter, say 1 and 1 to 2, 1 to 2, more than 2, 2. Mohs. So Mohs is actually discouraged in melanoma overall. There's a lot of debate and it's controversial. Maybe the areas that Mohs would be considered as especially melanoma in situs, like in maligna, or when you really need to conservatively save tissue. But again, that's another area of debate. Topical imicomod, lentigo maligna, not lentigo maligna melanoma, the in situ one. You consider it when surgery is not the best option because most of these patients come older in age, and a lot of them probably have other comorbidities. So sometimes you need to use an agent, and topical imicomod was used. Another option was tazarotene, I think was combined with topical imicomod. Different regimens have been used, but this is just kind of, I wouldn't say a palliative, but I would consider it as an adjunct type of therapy. But if you're able to excise, excision is definitely much more superior. So some stages, like to be, okay, did the excision, did the lymph node, all is good. Some new studies now are pushing further and further to add like an anti-PD-1 inhibitor for stage like 2B and 2C, not only the metastasis ones. And this was thought to be decrease the recurrence. So future-wise, we'll see more and more maybe modification and not only using these agents for advanced cases, but also using these agents as, let's say, adjuvant to what you're doing. And this is what we were talking about, stage 3 and above. You have to do a sentinel lymph node. And once you do have the lymph nodes, you dissect and remove the lymph nodes have to be removed. So when we come to distant metastasis, and this is stage 4 and beyond, okay? Two common classes. We have targeted kinase inhibitors and immune checkpoint inhibitors, okay? Targeted kinase inhibitors are very good, but what the problem is that they have is that they get resistant to the medication. Like the tumor starts developing resistance. Other older therapies like interleukin-2, this is terrible. I've seen someone take it, has a lot of side effects. Radiation is definitely last resort in some cases, just for palliation. A question rises, well, if someone has metastasis, do you need to actually excise the primary cutaneous one? Or you just treat it with... No, it's thought to be better because it seeds and it could cause local regional damage more than just that distant metastasis. So these are targeted and immune checkpoint inhibitors. So targeting the MAP kinase pathway, we have the BRAF, sometimes combined with the MEK inhibitors. and you can know by their names. See, the RAF is in the middle of their name, and the MEK inhibitors, you see ME. Okay, so they get combined, and usually it helps. And the problem with these, the only problem is the resistance that they develop. Another mechanism, which at the beginning we were talking about the immunogenic nature and how this occurs, is the checkpoint inhibitors. We had CTLA4, which CTLA4 blocks it. When you block the blocker, you keep the cell alive. So you kind of block the ones that block your CD8 toxic T cells. And when you block the blocker, your T cells keep activating and assuming and start attacking the tumor. Okay. And IPI and TRIMI, we usually use IPI, NTPD1, program death 1. And these are not only for melanoma. These are used in different Merkel cell, lung cancer, different types of tumors, because they are adding a new concept. Like cemiplimab is used for metastatic or cutaneous BCC, and different ones. See Merkel cell here, but you have anti-PD-L1, PD-1 antibodies, and these are anti-PD-L1 antibodies. So one on the tumor, one on the T cell. Okay, so know the difference. And this new agent in LAG3 antibody. So they're given in combination. So when you have these therapies, the targeted therapies, especially the ones that have tumors that have BRAF V600 mutation, you see a very rapid action. And when combined with a MEK inhibitor, even better, higher response rate, rapid tumor regression, and unfortunately, resistance develops, and then people tend to go to the immune therapy. So when we come to the immune checkpoint inhibitors, we have PD-1 and CTLA4 inhibitors, as well as PD-L1 and, as we mentioned here, the LAG3. So all these are the immune checkpoint inhibitors. What we have mainly the ones used, and we, at least in King Faisal, we get them oftenly with these patients. They take pembrolizumab, nivolumab, and ipilimumab. Could be used as mono or in combination. Okay, usually a CTLA4 and the PD-1 together. So these give long-lasting remission. They're very good. They improve overall survival. But the problem is what we're going to come to. Just before that, just to show you, this is what we meant. So you have an antibody that blocks the blocker. Okay, then the T cell keeps growing. And the PD-1 as well here with the tumor as well, from tumor cell and the T lymphocyte. And you can see if you block the blocker, the cell will keep surviving and produce and attack more the tumor. So immune checkpoint inhibitors are first line for unresectable stage 3, stage 4 metastatic, adjuvant for high risk, stage 2 and 3. The goal, as we said, is to enhance CD8 cytotoxic T cells and promote immune recognition and destruction of melanocytes. Because once you recognize it and the lymphocytes are in the system, they'll start attacking it in different seeds and different locations. And it has replaced the old, more side effect bearing therapies. CTLA4, again, just talk about compared to CD8, binding to B7, as we were mentioning before. And this is how it's done. It improves survival compared to older therapies, slower onset of response than targeted therapies. But this is what I was going to say. As you are doing melanomitis as inflammation to the melanoma, you get itis all over. And you get colitis, hepatitis, every itis. And I've seen that. And you can get vitiligo. And when you get leukoderma, vitiligo, that's actually a good sign. Okay? And this is the PD-1, PD-L1 blockade. Now you just mentioned that, and they could be synergistic with the CTLA4 blockade, and they tend to be stronger and less toxic than the CTLA4. Future-wise, we'll see more and more about vaccines and whether or not same concept, but how can I use a vaccine that attacks a tumor instead of a bug? Okay, and these are the old therapies that have been used. Just use as salvage, or when you have nothing that works, then you can add these to these patients just for survival. Thank you very much. This is the first talk.
يعطيك العافية دكتور سعود، والله مرة شكرا لك يعني على المحاضرة. في تقريبا دكتور عندنا questions في ال Q&A part، يعني هل تحب ناخدها دكتور إنه كل lecture بالأسئلة حقتها، ولا تحب إنه both back to
والله I'm just worried about time. I think we should go both lectures. كثير الأسئلة ولا سؤالين؟
هو سؤال واحد الآن في ال
إيه
Q&A.
خلاص، سؤال واحد I can answer it. No
واحد
problem.
أوكي. عندنا one question من دكتورة غيداء تقول regarding acral melanoma of nail, is it enough to send nail clipping specimen to pathology, or do we need to send nail matrix biopsy as initial diagnosis?
Okay. No, you have to. Look, when it comes to suspicion of melanoma, do you see me صح بالسكرين؟
I can see you.
Yeah.
نعم.
You know, حتى one of my colleagues كان يقول في كندا كان يقول if you don't know how to do a full يعني nail release or go into matrix, he used to take a punch and go directly here. He punches down and takes a punch and stitches as if. So if you don't have the equipment, that's not a wrong idea. I think that's much preferable. So to answer that question, no, nail clipping is not a diagnostic, because you won't be able to see the melanocytes and you're not able to see the type. But let me be very clear about nail melanoma. I've never seen a regular nail pigmentation or suspicious one ending up being a melanoma. Most of the nail melanomas from the beginning they look like a melanoma.
Okay.
اطمنكم, بس that doesn't mean take my word انه لا خلاص دكتور سيد قال انه no. It's one of the areas, because taking a biopsy from the nail is not fun, and you can cause damage that sometimes would lead to يعني maybe permanent nail misshape.
يعطيك العافية دكتور. So far it's only one question.
Excellent. I know it's a dry, boring subject.
لا بالعكس والله يا دكتور، ما شاء الله.
لا أزعجك. بس يعني really melanoma, you have to understand genetics, you have to understand the basis of pathogenesis, and once you understand that, everything becomes easier. Staging, unfortunately, there's no easy way to say it. It's very hard. And the other hard part is you get different patients with different stages. What do you do? So it's always difficult and confusing, but take general ideas, and inshallah that will be more than enough for your exam. So basal cell carcinoma. So I don't need to talk about it more than it's the most common human cancer. Basal cell comes from basal layer طبعا, has very low metastatic potential, can be highly destructive, especially locally. Mutations, you could get loss of function or gain of function. And we'll come to these. We'll come to them in figure, which I think is better. But just to tell, you'll hear hedgehog, and it's called sonic hedgehog. And this pathway, we'll see that again in a second on the graph, but inactivation of this pitch or patched protein is the most common alteration, especially 1. 2 is less common. So what happens is, as if the sonic hedgehog is always constantly active and leads to further growth of cellular proliferation. Another is smoothen gain of function mutation, also activates pathway. We'll know these in just 1 second. And patched is in large numbers of PCCs. I mean, the mutation is present. So you see here, this is the hedgehog signaling pathway. In a regular condition, you have patched, smoothened, sufu, glee, and then you go inside. Okay? So what tends to happen when you get the sonic hedgehog, which is the attaching to the receptor, there is dissociation between smooth and patched. It's like you release smoothing to activate, and it keeps activating downstream. And you can see when glee comes in, SUVA attaches to it and goes into the nucleus. So your target as therapeutic would be either here, or hopefully in the future somewhere here. Okay. Another pathway is called Notch signaling pathway. Acts as a tumor suppressor in keratinocytes mainly. If you look at the figure, it's like a binding ligand has an internal extracellular, intracellular part, and when it gets cleaved by a protease, its release goes down, translocates down to the nucleus, and it starts activating. So I think knowing this pathway is also important. Other pathways with sequencing have been noticed, like NMIC pathway, Hippo-YAP pathway. Alrighty. So these are, see this? When you see this pearl, you're 100% certain that this is BCC. Occurs worldwide, all races and all ethnicities, most common cancer in human overall. Usually associated with UVR, strongly associated with UVR, and mainly in fair individuals. But out of skin tumors in Saudis, it's hard to say I'm biased. I see transplant patients, but I would say the ones without transplant, BCC is the most common and usually pigmented. So epidemiology, UV exposure environment, UV irradiation is the strongest environmental driver. So annual, the more you get exposed, the more likely you have BCC. The more you're close to the equator, the more you have high BCC, or you have an area with high UV index. Both intermittent chronic contribute. And yeah, we're talking about the location and your lifestyle, all these influence the risk. Mortality from it is very rare. When death happens, usually in an immune compromised or patients that are syndromic, like Gorlin syndrome. Metastasis is rare, but it can occur, usually regionally to lymph nodes, lung, bone, skin, so in other areas of skin. Then how do you know a metastatic BCC from a primary BCC, or a metastatic melanoma from a primary melanoma? One thing is, on pathology, you'll see it dermal usually, and it's like a circle compared to something attached to the epidermis. And these are the aggressive subtypes, okay? Morpheoform filter tip, we'll talk about that. Again, in the US, it's the most common tumor, more in men. Again, I think it's more in men, not necessarily related to hormonal, or I think it's just the fact that the outdoor workers are mainly men compared to females. And its incidence increasing overall in the world because there's extended survival as well in a lot of people, and in younger people because of their behavior, tanning, outdoor recreation, somebody goes, and whatever tanning trends they're using, like salt water and whatever, all this unfortunately contributes. UVR is definitely the most common risk factor. The total UVI, total overall exposure to the time. So intermittent and tan, sunburns at any age increase the lifetime risk. Again, we're just repeating the same concept, but it differs slightly from SCC, okay? Because BCC is more intermittent sun exposure, but on long term, SCC is persistent low level of sun exposure. Indoor tanning, again and again has been increased the risk, but SCC more than BCC. PUVA, the medical one, is more SCC but also in slight increase in BCC, okay? But narrowband in TAR and UVB have no risk, and at least no documented risk or detected risk. And you can see BCC increase in psoriasis patients who received PUVA in the past. Radiation, so people who work in occupations, okay, more than 20 years, as you can see, latency, it takes a long time until the radiation spot. Even on treatment with radiation, it takes around 20 years for you to develop it. X-ray therapy, because in the past they used to treat tinea capitis with X-ray, and I've actually seen Persian patients in North America where they came, they had a lot of pigmented BCC. I saw 4, and funny enough, they're all Persians. Maybe it was the region I was in, but they all had treatment of tinea capitis with X-ray, or they have a genetic predisposition exposed to radiation. And outdoor workers overall have increased risk. Airline pilots, because cabin crew, because they're at a higher, you assume the UV. Different chemicals, arsenic. I have a couple of patients who it's very difficult to diagnose, but they have chronic arsenic exposure that leads to cancerization of their skin, developing multiple cancers. Phenotypically, just like melanoma, very close. So fair skin, freckling, red blonde hair, blue eyes, low melanin ability. All that just alludes that they have low ability for DNA damage. Syndromes that could be a risk of developing BCC, xeroderma pigmentosa. We have a couple of patients in King Faisal, a good number of them, and they do develop numerous BCCs. Oculocutaneous albinism, Gorlin syndrome, which is basal cell nevus syndrome. This is a syndrome you should know. Here in Saudi, we don't see it. It's more in Caucasians, but we used to see it in North America. Thrombo-basic debris crystal syndrome, Rothman-Thompson, and nevus sebaceous. So one of the tumors that could develop is a BCC. Gorlin syndrome, I remember them. They have like macrosomia, frontal bossing. They have like jaw changes. They have coarse features a little bit, and they have these numerous BCCs. And mainly because of activating mutation. So the patched one is always active, so smooth, and it keeps downstream activating and proliferating. Patch 2 mutations is less. And one alarming sign in them that they develop basically early in their life, often, but before and around puberty time, usually around their 20s. And you can see the criteria. There's major and minor. So one basal before the age of 20 or excessive number of BCC. Odontogenic keratinocysts, and these are what we're seeing. And this is best by a panoramic view of the jaw. Pits, lamellar calcification of falx cerebri. And you can see this on an X-ray by AP. Medulloblastoma in childhood and first degree relative with the syndrome. Other minor criteria is macrocephaly, skeletal abnormalities, vertebral rib abnormalities, ocular abnormalities, cleft lip palate, ovarian cardiac fibroma, lymphomesenteric. I remember a question was that this patient, when birth, he had a heart issue, I think, or something. And what could this be? They mentioned that he had basal cell nevus syndrome and developed cardiac problems, blah, blah, blah. And the question was that they developed fibroma, cardiac fibroma or something. Other syndromes, basic debris crystal, excellent genetic. You can look at the features, but they get early BCCs, Rambaud syndrome, Zoma dominant, and they always like to ask you to differentiate between two. Immune suppression. And this, to me, in our population, is increasing the risk, especially with transplant. So solid organ transplant have 5-10 higher BCC. And that's why we see much more actinic keratosis SCC in these patients compared to BCC or melanoma. And of course, medications that are used as well could increase more, like Imuran, which they are changing now as a thioprin, and voriconazole. These two could affect the P53 directly. This is more towards SCC. And they tend to have aggressive and more recurrent. And yeah, so it's one of the burdens when you have multiple and field that just keeps developing cancer. And this is what we call field cancerization. It's like the area when you develop a cancer here and you have damaged skin, most likely the whole area is cancerized. So you can develop cancer at any of the locations. It's better off when you treat, especially with the topical therapies, is that you apply it in the involved area. Could occur BCCs on any hair-bearing area, but also none. Head and neck most common. It could be trunk extremities, and these are tough locations in acanthi, small areas. This is where Mohs micrographic surgery is much more useful. And you can see on dermoscopy, you can see these changes. Major subtypes, and this is clinical pathological, is nodular superficial morpheoform and fibroepithelioma pincus. So nodular is the most common type compared to superficial spreading in melanoma. You can have more than one subtype in one lesion. Nodular ulcerates more. Melanin could be present in all subtypes. So this is your typical pearly papule with a vessel, and you can see arborizing vessels. So nodular most common subtypes, around 50% of all BCCs, shine pearly papule or nodule, usually have arborizing telangiectasia. And they can be large and ulcerate, and this is what we call rodent ulcer, if you see the ulcer of a BCC. And they can be pigmented, especially in our population, they're mostly pigmented. Yeah, and this is just the same features we were talking about. And BCCs overall are very, very slow growing. So they take a while until they grow compared to SCC and compared to melanoma. This one is more confusing. So if you find a psoriatic plaque that is not responding to therapy, I strongly recommend you biopsy it sometimes, especially when it's in a single lesion. Could be bones or superficial spreading, superficial basal cell carcinoma. Erythemas, I find it the most challenging part of it is it can mimic other conditions. It can be thin, thick plaques with scale, and the borders could be elude a little bit. You see pearliness on the edge, but sometimes it's very hard to detect. And regression could occur in it, and it causes like hypopigmentation and atrophy. And it's the most common subtype in younger people. Trunk and extremities. So you can see the location, everything is a bit different than nodular, and it has more a horizontal spread, can be big in size. All right. So this tumor I used to see also often in North America, and these, you see them, they look like lichen sclerosis, alomorphia. This is morpheoform sclerosing BCC. Least common. Area is indurated, and when you move it, it's like a piece, thick dermal piece. And as you mentioned, it looks like morphea and has an aggressive, and it's very difficult to remove because every time you remove, what you see outside is just sometimes the tip of the iceberg. This one, this is the lower back. It looks like a polypoid skin tag, and this is what fibroepithelioma, epithelial or fibroepithelioma pincus. It's not that bad of a subtype, but it always asked which location, etc., etc. and its pathology is kind of um, unique. It has like a fenestrated look of the epidermis and the strands of the BCC. Dermoscopy. So again, it's very helpful and very useful. But honestly, I find BCC easy to, by the naked eye, to diagnose it. So we were talking about arborizing blood vessels, micro and macro ulcerations, blue-gray ovoid nests, multigray blue-gray globules, leaf-like. I think these are going to be another lecture, dermoscopy. But this is kind of what we talk about: ulceration, arborizing vessels, globules, nests, etc. Reflectance confocal microscopy. I've seen this, but it was more experimental in the lab. You actually see it like this. You see the nest, the tumor, and you can see it, and it is helpful, but I don't think it's that readily available in the market. But it is one of the useful, I guess, devices for detecting the tumor. Pathologically, we all know palisaded, cleft, and then a fibromyxoid stroma and nests. But the problem with this pathology could look like trichoblastoma, a lot of others. So I encourage you to know how to differentiate. And the cells are very tight to each other. You can't even see the desmosomes between them. Pathological subtypes, we have superficial, nodular. Superficial will be in the superficial epidermis. Nodular is the typical one you just saw. Micronodular is the same, but small pieces of islands of basaloid cells. Pigmented, it's the same thing with pigment. Morpheoform is more difficult. I think I have a picture for that. And fibroepitheloma is also a bit unique. Basosquamous is a tumor which doesn't know where to go. Should I go SCC or basal? Or whether or not it's a merge of two. So it has both features, okay? Yeah, so this is the morpheoform. You see the strands and all this stroma, and it's like a fibrous tumor. This is fibroepithelioma of pincus, and this unique fenestrated look is typical for it. Basosquamous, as you can see, this is typical BCC, and boom, you get these eosinophilic, pleomorphic, atypical looking cells, and this is why we call it basosquamous. It's bad, more aggressive, and it's one of them that needs attention. And I've seen it. I've seen it when one of the rotations I used to do in Mohs surgery, and you see both features of SCC and BCC. Treatment modalities, whatever you do to destroy the BCC. So the more elegant you are, the better cosmesis. The more aggressive you are, the worse cosmesis, okay? So for very good cosmesis in a very elegant place, you'll get Mohs micrographic surgery, and it will help spare tissue and give you a better cosmetic outcome. We'll go through some of them. So standard excision, 4mm surgical margin to be safe. And yeah, that's your typical elliptical, where you can do it without needing to spare tissue or you're in a tight area. Curettage and electrodesiccation, this is very helpful, and it's actually a very good technique. But the unfortunate part is it gives a very bad cosmetic outcome, but it's fast, cost-effective, and very cheap. I honestly think it's useful, especially when resources are limited. And same to that is excessive cryotherapy. And these are preferred for superficial types, not like morpheoform or the big nodular types, and probably second line for nodular. Mohs micrographic is excellent when available, especially that it has tissue sparing ability. It's good for tight locations, small locations, and it decreases the risk of recurrence. Radiation is used especially when surgery is not tolerable. Has disadvantages, as you know. Margin is not well controlled. Cosmetic outcomes not the best. It's a lot of sessions for them to get, and they can develop sarcomas or future cancers in the future. And just to allude, morpheophone is radio resistant, and do not use it in syndromes like Gorlin. PDT, we used to use it in North America. Again, you curettage, you put a sensor that has porphyrin and goes in, and then you add the light. After that, it kind of interacts with each other. So it's kind of the same concept, but it does have a better cosmesis compared to other destructive modalities. Laser, funny enough, PDL could help because you're targeting the vasculature. Ablative techniques like ablative CO2 or erbium all could be of help. Topical therapies, 5FU, you can use it, very effective and it's good. Imicomod is another option and has good clearance rate. Do you only spare these for superficial subtype? Don't want to go for nodular or deep ones. An advanced BCC. Okay, you tried, nothing worked, lesions are persistent, or you have metastasis. And when I talk about lesions, had people who had 30 centimeter ulcer on their trunk from a long history of BCC, or on the face, or etc. Okay, so these are the criteria when to go. And it's also beneficial with people with syndromes because they keep getting like Gorlin, specifically speaking. So hedgehog pathway inhibitors, we have vismodegib, which is smoothing antagonist, proved for advanced metastatic, as well as sonidegib. Okay, both work on the smoothened, and this is where patch and smoothened. So either lock this or lock this, because if you remove patch, smoothen is active. So when you inhibit smoothen directly, despite the patched availability, it will not go downstream and activate. And this is an example of how vismodegib could give you excellent results. And it's considered palliative. It's not, I mean, hopefully this is cured, but you can see almost the ribs are exposed. So side effects of vismodegib overall, what I remember, the worst is dyschezia, muscle cramps. I remember when he said the cramps are so severe that he cannot sleep at night. And other things, alopecia, diarrhea, fatigue, and all other. And you can see switch of BCC to SCC. It's a phenotype switching. And that's where I entertain the idea of basal squamous. Risk factor of recurrence. I think you guys should review this table, and it's good. It depends on the subtype. For instance, like if it's nodular superficial, low risk compared to micronodular infiltrating sclerosing. So these are bad types of BCC. And for BCC itself, the rest you can see the comparison between both. Thank you very much.